Hello. I'm going to be talking to you over the next few minutes about fetal cardiac imaging. What are we and our guidelines doing wrong? Or in other words, why do we collectively continue to miss even major forms of heart disease prenatally? I'm Dr. Mark Sklansky. I'm a professor in chief of pediatric cardiology at the David Geffen School of Medicine at UCLA. I have no disclosures to make other than my chapter, from which many of the schematics that you'll see in the next few minutes during this presentation come from my chapter in Creasy and Resnick's Maternal Fetal Medicine textbook. So the real issue is, why are we still missing major heart defects prenatally, and what can we do about it? How can we be better, and how can you be better when you go back to your practice so that the next case of major heart defect that you encounter, you pick up before birth? As we discussed in this editorial, there are a few secrets that I want to impart to you over the next few minutes that really encapsulate what, in my opinion, are the most important reasons why we're missing and what you can do about it when you go back to screen the next fetus. Well, let's look at what are the current screening guidelines for low-risk pregnancies. What are we required to do? I'm looking just at a couple of guidelines from the American Institute of Ultrasound Medicine, published in 2013. And the same year, the guidelines from the International Society of Ultrasound and Obstetrics and Gynecology, published in 2013. So this is the essence of what I'm going to be talking about over the next few minutes that I want you to take home with you. These are the aspects of fetal cardiac imaging that I think are most important. And you can see that they're not all required in the current guidelines. So actually, what I'm going to be recommending to you is to go beyond what our current guidelines require in terms of screening low-risk pregnancies for heart defects. And I think that's necessary, and I think the guidelines ultimately will catch up, and ultimately we'll be doing the right thing for all children born with congenital heart disease. You can see we're going to be talking about the importance of clips, the importance of color flow imaging, the importance of looking at the outflow tracts, the three-vessel view, and what has not received nearly as much attention as it should, in my opinion, is the importance of angle of acquisition and scanning techniques. As you know, it's really the key is the sonographer or whoever's doing the scanning. And if they are not doing the scanning correctly and optimizing image quality, heart defects are going to be missed. What about screening guidelines, beyond screening guidelines? What about high-risk pregnancies that are felt to be at high risk for heart defects? What do those guidelines say? Well, here we'll look again at the ISWAG, or International Society of Ultrasound and Obstetrics and Gynecology. Their guidelines published in 2008. The AIUM in 2013, and then American Heart Association issued some guidelines or suggestions in 2014. These guidelines, again, for high-risk pregnancies, do always require clips or cines, require color flow imaging, outflow tract and three-vessel view evaluation. But interestingly, even for high-risk pregnancy, the guidelines fail, in my opinion, do not stress the importance of angle of acquisition, except a little bit in the ISWAG guidelines, or the importance of scanning techniques, which I'm going to talk to you about during this presentation. So let's go over each of these areas in turn, because I think if you take home these pearls, I promise you that you will improve your ability to detect heart defects in the future and ultimately your entire practice's ability. Let's start with clips and sweeps. This has been known for some time, but it's still in many practices difficult to archive or to acquire clips and to store them. But I think this is a problem. I think any of us who are involved with fetal cardiac screening need to be able to acquire and store clips. If you look at this four-chamber view of the heart, it's difficult to tell what's going on with the mitral valve. We don't even see a mitral valve. The tricuspid valve isn't moving. If you let the heart beat, you'll be able to evaluate the valves much more closely. And as you know, there can be a subtle abnormality of a valve at 18, 20, 22 weeks, which is when we commonly evaluate the heart. That can become much more obvious and much more clinically important as the pregnancy progresses. So you don't want to miss even a subtle cardiac anatomic abnormality when we do the screening, and you can't be sure of that unless you're looking at the heart beating in real time. Beyond a clip are sweeps, where you take a four-chamber view, sweep to the outflow tracts. Now you might think, well, listen, I don't even do clips. It's going to be very difficult for me to do a sweep. It's hard enough just to learn how to do a clip. I can tell you, though, actually doing a sweep is actually easier in some sense. And you should, if you're not doing this now, you should do it when you go back to your practice on the next baby, the next fetus. As you put your probe down, do a sweep, gradually go from the four-chamber view to the outflow tract, or from the outflow tract LVOT to the RVOT, or to the three-vessel view, and you'll learn how one part of the heart relates to the other part of the heart, and it'll help you in the future to be able to evaluate all aspects of the heart. So actually adding a sweep to the concept of a clip is actually to your benefit, and it's not very complicated, it just requires practice. Okay, let's turn the page talking about color flow. As you noted in the guidelines that I showed earlier, and you can go back if you have this presentation on your computer, go back, and color flow is also still not required in low-risk pregnancies. But again, just like clips, I think color flow should be part of every fetal cardiac screening evaluation, even in low-risk pregnancies. So it's going above and beyond what is currently required by some guidelines. What are we seeing here? Well, we're seeing over here a ventricular septal defect that would be missed without color flow. We're seeing pulmonary valve regurgitation that the valve would have probably be thought to be normal without color flow. We're seeing some evidence maybe of coarctation of the aorta that might be missed without the addition of color flow Doppler. So these are areas that help to demonstrate the importance of adding color to your routine screening examination. It's also important in terms of looking, this is a case of tricuspid regurgitation. Sometimes the amount of regurgitation or other aspects of the fetal heart that we identify only with color can be helpful for us in terms of counseling. Counseling is so key in terms of prenatal diagnosis of heart disease, and color flow really can make a dramatic difference in how we counsel, what the prognosis for a given baby might be. Finally, in terms of color flow, this is a case demonstrating, a clip demonstrating retrograde flow into the ductus arteriosus. This is suggestive, say, in a case of tetralogy of Fallot. Many cases, even today, of tetralogy of Fallot, as you know, are still being missed. The vast majority are still being missed. And the cases that we really don't want to miss are the ones that are ductal dependent, that will require intravenous administration of medication soon after birth to provide the best, the most optimum outcome for these children. And by doing color flow, we can see it's retrograde flow. It gives us a clue. This is a fetus when the baby is born is going to be sick, is going to require intravenous medication as a life-saving maneuver. So if you're going to use color and you haven't been using color, just want to give you a couple tips on how to do color. Because like all things, there is a learning curve, but I promise you, if you're doing fetal cardiac screening at all, you have the intelligence, you have the ability to add color to your armamentarium. Here's a typical clip of a four-vessel view. Let's say you want to look for a ventricular septal defect. As I'm going to talk to you about later, angle is so key. So even before you put color on, you want to change the angle by manipulating how the baby is lying. Here, the ventricular septum is perpendicular to the ultrasound beam. Here you could see there's a lot of artifact. It's hard to interpret, so we need to use gain and sensitivity of the color to optimize the picture. And here we could see that there's no ventricular septal defect, and we're perpendicular the way we need to be. Here's another example. This is a baby's heart that looks normal, and there's no evidence of a ventricular septal defect in this view. But when we go perpendicular in this way, you can see even here when we're perpendicular, we do not see the dropout. We do not see the ventricular septal defect. When we add color over here, it's very obvious. Finally, pulmonary veins can be very tough to pick up prenatally, but honestly, in my opinion, even for low-risk pregnancies, you should strive to see at least one pulmonary vein, and you can do that by 2D, or you can do it with color. Here you could see the color is not useful at all. Here the color is not useful at all because we've dropped the gain so much we're not seeing any flow at all. But then if we optimize the gain, we optimize the settings, and we can see the pulmonary veins. Very key for looking at pulmonary veins is to orient the 2D image in such a way that you know where the pulmonary veins should be, and that they're either going to be coming towards the probe, as in this right-sided pulmonary vein, or away from the probe, as in this left-sided vein that's blue. That's key to optimize the 2D image and to make the pulmonary vein parallel to ultrasound beam before you put on the color. Okay, let's go to the next secret or pearl that I want you to take home, is the importance of outflow tract evaluation. Years ago, people were not doing outflow tract evaluation. Guidelines just included a four-chamber view. We've learned a lot, and in fact, in many respects, it's the outflow tract lesions that are perhaps the most vital to detect prenatally, because it's largely the outflow tract lesions that are often ductal dependent, that require early neonatal intervention. And so those are the ones you certainly want to know about beforehand. It may even affect where you want a baby to deliver. Here's a 4-chamber view of a heart that has an atrioventricular canal defect. AV canal defects constitute a major heart defect that will require surgery, but not requiring surgery usually during the neonatal period. Outflow tract lesions, on the other hand, often are ductal dependent and often do require intervention right away. This is a case of transposition. The left ventricle is giving off the pulmonary artery, the right ventricle is giving off the aorta. This is a baby who very well may require not just prostaglandin, which is an IV infusion, but may require an invasive procedure, a balloon atrial septostomy within hours after birth, very key to identify transposition and other such defects prenatally. And the only way to do that, of course, is by looking at the outflow tracts. Then finally, the 3-vessel view. This is relatively new to the scene, relative newcomer, but I'm convinced that a 3-vessel view, even though it is not required currently in most guidelines in low-risk pregnancies in terms of fetal cardiac screening, it's very important. This is a nice example demonstrating the spine back here. This is the superior vena cava, the aorta, and the pulmonary artery. And what's this over here? That's the trachea. So we're seeing the aorta going to the left of the trachea to join the pulmonary artery, demonstrating it's a normal left arch. Many cases of right aortic arch can be detected just with this view. As you know, many cases of right aortic arch can reflect the presence of DeGeorge syndrome or other abnormalities in the heart or other parts of the baby. So even a rightward aortic arch that can be detected readily with a 3-vessel view can be very important in terms of leading to other diagnoses. Finally, we've talked about clips, talked about color flow, outflows, 3-vessel view, all of which, or most of which, of course, go beyond what's required, but I urge you to do that in your own practices. But finally, angle of acquisition and scanning techniques, very, very important to take home some of the messages I'm about to discuss. So, how do we optimize the image? So key, but really very little of this is discussed and certainly not discussed or mandated in our guidelines. How do we optimize the image? How do we go from this, which is, I must tell you, if you do not scan, if you're not a professional who scans the heart, this is actually a very typical view of the heart that without optimizing the image, this is the best we're going to get. How do we go from that to this? I promise you it's the same baby. We can definitely see this type of heart coming from this with just a little bit of manipulation. It takes some time, not a lot of time, but of course, it's worth it. So how do we optimize image quality? It's so key. We're talking about hearts that are quite small, size of a quarter. The valves are much even smaller than that. We don't want to miss even a subtle abnormality. We need to optimize the image quality as best as we can. Number one is choose the best probe. We want to use the highest resolution probes that has adequate penetration. We want to optimize, and this is very key, we want to optimize the probe position on the maternal abdomen. If you don't get a good picture here, don't just stay there. Move all over the abdomen, finding the best window. It can make a huge difference. It can make all the difference in terms of whether you pick up a heart defect or you miss it. And then finally, you want to optimize the maternal and fetal positions as well. How do you do that? Well, the maternal position, you have her move on her left, on her right. Just this morning, I was scanning a woman. She had to jump up and down a few times to go to the bathroom. Sounds silly, but it really can make all the difference. And in terms of the fetal positions, as I mentioned earlier, and I'm going to talk a little bit more, the angle of acquisition, how are we evaluating the heart? Are we perpendicular to the septum or parallel is so key. And one way to get perpendicular, say, to the ventricular septum is to move along different places in the maternal abdomen, but another one may be to get the baby in a different position so that you're coming perpendicular or parallel as you need to be. Oh, and finally, is not to be forgotten, although I'm told many, many times I go to people's offices and I start scanning and they say, wow, Dr. Slansky, I didn't realize we could get this kind of an image on our system. And ultimately, really what I'm doing that they aren't doing is I'm pushing a little harder, and the patients will tell you that. It doesn't hurt the baby. The baby will tell us if we're pushing too hard, but a little bit extra transducer pressure can make all the difference in the world. Depth. Here's a case just demonstrating some of what I've just been talking about. If we look at this case, we're wasting all this resolution over here. We can go from 18 hertz to 29 hertz just by changing the depth. Again, optimizing the image has real clinical implications. Here we're removing the sector width and the zoom. The sector is way too big. All this is wasted resolution, so we need to narrow it. And look, we're going from 35 to 114 hertz, which correlates with image quality. Now let's talk about the angle of acquisition. I mentioned earlier a little bit when we were talking about how to use color to look for ventricular septal defects. Now we're talking about angle of acquisition, the importance of it when you're looking without the use of color, just to look at the ventricular septum. This is a case, a still frame image. You won't see a lot of still frame images during this presentation for a reason, but if you look here, it looks like there's a big hole here and in that ventricular septal defect, like an AV canal. Taking the same baby and looking perpendicular, it's completely intact. Very key, very clear, and very reproducible every time you scan a fetus. This is a 4-chamber view of a normal heart. The crux is intact. Everything about this is normal. Now we're looking at this heart, and it's very obvious because we've optimized the image and the angle that there's a large primum atrial septal defect. This is a type of AV canal. The tricuspid and mitral valves are at the same level. This is an AV canal defect. Many cases of AV canal defects, even though they're 4-chamber views, are still being missed throughout the United States and beyond. And I think a big reason for that is because we're not optimizing image quality and angle of acquisition, things that you are not going to forget to do when you go back to your practices. Here again is just another example, perpendicular to the ventricular septum. Cannot see the VSD in this case without color, but with the color we can see it. This is an angle parallel to the ventricular septum, looking the aorta coming off the heart. This is not how you want to evaluate for alpha tract abnormalities. A big X, please do not do this. You're going to overcall or undercall, override, and you're going to miss major forms of heart disease if this is the way you're evaluating outflow tracts. This is the way we want to look at the outflow tract. This is one of my favorite views. Over here you can see the left atrium, the left ventricle, and the aortic valve and mitral valve, just as in the schematic. And there's continuity in the septum all the way out to the aorta. On the right, you could see this is a case of tetralogy flow. Many cases, actually most cases in most of the world, are still being missed, but shouldn't be, because as you can see, there's obvious override. It's obvious for those who are scanning, who have been scanning for a while. There's override of the aortic valve of the aorta over the crest of the ventricular septum. If you are not looking parallel, if you're not looking perpendicular rather, this is even tetralogy flow can be missed. This is another type of ventricular septal defect called a membranous ventricular septal defect. You can see this fluttering of tissue that's trying to close this defect in the membranous septum. Very difficult to pick. This is a baby with Down syndrome that I was evaluating initially. I wasn't able to see this area very well. I had the baby come back, got a good perpendicular view. It's very obvious that this baby has a large defect here, partially closed by this aneurysmal tissue. Finally, optimizing maternal and fetal positions. As an example, this baby's heart is the ventricular septum is parallel to the beam of the ultrasound. We don't want it to be that way. We need the baby to move in this configuration. However, you can do that. So here we've moved the baby, so now we're perpendicular to the septum, but we've gone from 40 to 32 hertz. Now we need to use the other elements of the scanning techniques that I described to you to optimize the image further. So now we need to narrow the sector, use the zoom, optimize the picture, and come to this. And now you're in a position really to rule out major forms of heart disease, but only after optimizing the image. So now we talked about the importance of clips and maybe even sweeps. We've talked about color flow. We've talked about the importance of angle of acquisition, optimizing the image. I want to talk to you now about the key views that you always want to get, even though guidelines may not require them. I think you should try to do them in your practices from now onward. Abdominal situs view, 4-chamber view, outflow tract views, and the 3-vessel view. That's it. If you're not used to doing them, I promise you, if you start doing them and practicing, you'll be able to do it and you'll know that you're doing the right thing. Abdominal situs, all we need to look at, spine, descending aorta, stomach on the left. You have to make sure it's on the left. Sometimes it's not so easy to tell, but you need to make sure it's on the left. You need to make sure the heart's on the left when we get to that. But in the abdomen, you want to make sure you see the descending aorta, anterior to the spine without a large vessel behind it. You can have a small azygos, but it shouldn't be that big as long as you have an intact inferior vena cava over here, anterior and rightward, and the stomach should be on the left as well. Let's look at an abnormal. Everything's normal except we have this large azygos behind the descending aorta. This can be a clue to heterotaxy syndrome, which is often associated with other cardiac abnormalities or actually abnormalities outside of the heart as well. So sometimes within the abdomen, we can see major abnormalities that can give us a clue about what we're going to find when we go above the diaphragm, particularly when the stomach is on the wrong side. Now we come to the four-chamber view, very important. Four-chamber view used to be the end-all and be-all for fetal cardiac scanning, and it's still a critical part of low-risk pregnancy fetal cardiac screening. Here's a nice schematic, and you can see the same anatomy on the right. Notice it's beating. That's the only way we can evaluate the valves. Very important to look at the tricuspid. Mitral valves, see how they move, open up, and they're nice and thin and delicate. You can see the crux of the heart. See, the mitral valve inserts a little bit more towards the base, the tricuspid valve a little bit more towards the apex. They're not at the same level. They're a little offset. That's very important. Along those lines, we see the lower part of the atrial septum here as well, also very important. Now, these components of the heart contribute to the crux of the heart. When the crux is not intact, it suggests the presence of an AV canal defect, which commonly can be associated with trisomy 21. We also want to see that the right side of the heart's a little bit bigger, usually about the same size, or a little bit bigger than the left side. The right atrium a little bit bigger than the left atrium. The right ventricle a little bit bigger than the left ventricle. And you can see the right ventricle is more trabeculated and often has, you can see the moderator band towards the apex. In contrast, the LV is more smooth-walled. And you'll also want to see towards the back that there's not a large distance between the descending aorta and the left atrium. When there is an exaggerated distance, it suggests that may be total anomalous pulmonary venous return. But even beyond that, you should be able to see, if you optimize the image, the pulmonary, at least one, if not two, pulmonary veins draining into left atrium. We also want to see the foraminal valley should be within the left atrium, should not be deviated into the right atrium because the flow should be from right atrium to left atrium. And of course, we want to look at how the heart is squeezing. We want to look at the heart rate. I do this by my eyeball, but you may want to measure the heart rate. You may want to measure the function, and there's very sophisticated ways to measure cardiac function at this point. But this is pretty much the four-chamber view. And I can tell you, four-chamber view, they say four-chamber view. When I scan, there's actually multiple four-chamber views I need. The way I'm holding the probe to look at the mitral valve may be different than the way I need to hold it optimally to look at the tricuspid valve, or optimally to see the pulmonary vein, or to even see the cardiac apex. And also, remember, we're going to want to look perpendicular to look for ventricular septal defects of the four-chamber view. But to look for AV valve regurg, tricuspid mitral regurgitation, we're going to be parallel and put color on to look for regurgitation. So it's actually multiple four-chamber views that you should be obtaining in every scan. Here's an abnormal four-chamber. What's wrong with this heart? Any guesses? This tricuspid valve and their RV do not look normal. The tricuspid valve is not opening up well compared to the mitral. The RV is more trabeculated. And this is a fetus that actually has tetralogy, not tetralogy, but intact septum with pulmonary atresia. Here's a left ventricular outflow tract view that you can see from going from left ventricle, the aortic valve, and the ascending aorta. You don't want to just stop at the valve. You want to show the aorta going all the way. And this is very key in terms of the detection of transposition, primarily, but other outflow tract abnormalities as well. Because you can't tell if this is an aortic valve or a pulmonary valve just by looking at it. But you can tell if the valve is well formed. But that's only if you look at the heart beating and if you put color on to see if it's leaking or if there's evidence of turbulent flow across it. So you need to look at it very carefully by 2D imaging. We always tell our fellows, our pediatric cardiology fellows, do 2D imaging first, always with sweeps, and then put on color. Same thing applies to fetal cardiac imaging, even in low-risk pregnancies. So here you can see continuity in the septum all the way out the aorta. The aortic valve is well formed. It disappears during systole, and during diastole, it comes to a point in the middle of the vessel. This is an abnormal left ventricular outflow tract. What's abnormal here? The aortic valve is very small. This is a case of severe aortic valve stenosis that may progress on into the form of hypoplastic left heart syndrome. But even if it did not, it's a significant heart defect. It's likely to be ductal dependent after the baby is born. Not something you want to miss, but you certainly will miss it if you're not looking at the morphology and function of the aortic and pulmonary valves as much as you are looking at the mitral and tricuspid valves. How about the right ventricular outflow tract? Also important. You could see the left ventricle, the right ventricle, pulmonary valve, main pulmonary artery. Pulmonary valve, just like the aortic valve, should disappear during systole and during diastole. Comes and looks actually like a plate that's perpendicular to the long axis of the pulmonary artery. It's actually for the aorta, it's often going to be parallel to that's extra credits actually when during diastole, the aortic valve may be in midline, but parallel to the long axis of the aorta. With the pulmonary valve, it's often perpendicular. That's a normal. How about an abnormal? I hope all of you can tell the difference between that last clip and the way the pulmonary valve looks here. Now, if you're not looking at pulmonary valves closely in real time, even this type of valve could be missed. If you put co-flow, you definitely wouldn't miss it either because it would be very turbulent. Finally, the three-vessel view I showed you earlier, you could see the pulmonary artery and the aorta coming to the left of the trachea, and here's the right-sided SVC, or superior vena cava. This is a case of a rightward aortic arch. This baby may be at risk for not only a vascular ring, but other cardiac defects or even DeGeorge syndrome as well. Finally, importance of sweeps. I think this is final. We're getting close to this presentation. I hope you're still with me. As I mentioned, when we train pediatric cardiology fellows to evaluate the heart within hours or minutes after delivery, it's always with sweeps. That concept of sweeps you should take home to your practice. Even if you think it's scary, it's actually not. It's actually very useful and very practical. Here's a case on the left of normal, showing you that the stomach is on the same side of the fetus as the heart. They're both on the left. Stomach to the heart. Stomach to the heart. Over here, it's abnormal. If you start in the abdomen, the stomach's on this side, the heart's over here. Very abnormal. You know that this baby is at risk for significant heart disease and heterotaxy right away. How about the four-chamber view to the outflow tracts? Again, you might be intimidated in the beginning, but really, I promise you, once you start doing the sweeps, you're going to find that you're learning, you're going to enjoy it, and you're going to be doing the right thing for your patients. So here on the left, you can see a normal sweep from the four-chamber view, left ventricular outflow tract and right ventricular outflow tract. Again, it's not just how they cross that's important. It's looking at the morphology of the four-chamber, the morphology of the aortic and pulmonary valves, and looking at the aortic going all the way up. You want to show it going all the way up and then the crossing, because with transposition, you can be fooled. And that's why transposition is such a difficult diagnosis to make prenatally. But if you follow the aorta all the way up, you won't miss it. This is a case of transposition on the right. If we do a sweep and we go from the four-chamber view, notice what happens to that vessel coming off the LV. It goes straight down and bifurcates. It's a pulmonary artery. The sweep shows from four-chamber. It's a pulmonary artery. It's not an aorta. It's just as simple as that. It's just a sweep. Obviously, it takes some practice, but honestly, just with a little practice, you will be able to feel very comfortable that you and your colleagues will not be missing additional cases of transposition or other outflow tract abnormalities with this simple maneuver. And then here's going, finally, a sweep from a outflow tracts or the four-chamber. You can follow the aorta and you can see what the vessels are. The left ventricular outflow tract, the aorta comes here, twists over and goes to the left of the trachea. In this view, as I showed you before, the aorta comes up and it goes to the right of the trachea. It's a rightward aortic arch. So, finish up, just under 30 minutes. What are the take-home points? What are the essence? What's the essentials of fetal cardiac screening? And why is this important? I think you know why this is important. There's three things I wanted to start out with that you probably already knew. One, that congenital heart disease represents by far and away the most common form of defect. Number two, that it makes a huge difference when we pick up heart disease before birth. So for so many babies born with major heart disease, if we know about it ahead of time, we can optimize where the babies are born and what we do for babies right away after the babies are born. And number three, what you also probably know is how difficult it is to pick up heart disease, but you also know how important it is. And I think what I've gone over today is going to help you when you go back to your practice not to miss the next case of major heart disease. And so to summarize, what are the essentials? Number one, image quality. Can't emphasize it enough to you. Please take the extra time, learn the maneuvers to optimize image quality. The guidelines don't require it. They should require it, and I'm hoping that they will require it in the near future. Angle of acquisition, likewise, not required by most guidelines, not specified or explained, but so key in terms of picking up heart disease. You need to optimize angle of acquisition, both for 2D and color. The importance of clips. You need to acquire and store clips, and I would urge you to try to utilize sweeps as well. It may be actually easier and more helpful to you than you may realize. Abdominal, what are the views? Abdominal situs, four-chamber, left and right ventricular outflow tracts, and the three-vessel view, all very important, even in the low-risk fetal cardiac screening examination despite guidelines not requiring them just yet. And color Doppler, as I mentioned, very key, and I think should be part of your armamentarium even for low-risk cases. Finally, practice. It just takes practice. If you don't do it, if you don't practice, you're not going to learn it. But I think with practice, you're going to get much better. You're going to feel good about yourself and your practice, you'll be doing the right thing for your patients. Thank you for attention. It's been 30 minutes. Please take these lessons back to your practice, and I promise you your patients will thank you. And I thank you very much for joining us today. Thank you.